Hello, everyone. I am Dr. Syed Mudasir Qadri. I'm Associate Professor, Department of Internal Medicine at Sher Kashmir Institute of Medical Sciences, Srinagar. So today, I'm going to discuss about the rationality of combination of SGLT2 inhibitors and DPP-4 inhibitor combinations. So let's divide this talk in a few questions. Okay, let's sort them one by one. So the first point, what are the benefits of combining antidiabetic agents such as SGLT2 inhibitors and DPP-4 inhibitors when initiated in patients? So let's discuss this first. So as we know, SGLT2 inhibitors is a class of novel oral and glucose lowering agents that mediates glucose lowering action by increasing urinary glucose excretion via inhibition of sodium glucose cotransporter 2 in the proximal convoluted tubule of the kidneys. Because of the progressive deterioration of beta cell function that characterizes type 2 diabetes mellitus as a disease, a pharmacological action that is independent of pancreatic beta cell function makes SGLT2 inhibitors suitable to administer at any stage or disease course, because their action is independent of the beta cell function. However, SGLT2 inhibitors resulted in 7.8 times increase in plasma glucagon concentration, which was accompanied by a 70 to 30% increase in endogenous glucose production. So this later effect has been estimated to neutralize the effect or offset the effect of SGLT2 inhibitors, approximately half of the glucose excreted in the urine because of this SGLT2 inhibitors. So the salutary effect of SGLT2 inhibitors is its ability to act independent of insulin secretion and action and render it suitable to administer at any stage of disease course. DPP-4 inhibitors exerts its action, glucose lowering effect by the elevation of incretin hormones and subsequent augmentation of glucose-dependent insulin secretion and inhibition of glucagon release. So if we combine these two agents, it has a potential to show additive glycemic control due to their complementary effects. So another part, what is the clinical rationale of combining SGLT2 inhibitors and DPP-4 inhibitors? So before going on to this, let's discuss the incretin effect. The incretin effect is a difference in insulin secretory response from an oral glucose load in comparison to glucose administered intravenously. The incretin effect is responsible for 50 to 70% of total insulin secretion after oral glucose intake. The two naturally occurring incretin hormones that play important roles in the maintenance of glycemic control, that is glucose-dependent insulinotropic peptide, also known as GIP or incretin, and glucagon-like peptide, also known as GLP-1. These peptides have a short half-life, very short, as they are rapidly hydrolyzed by DPP-4 enzyme within 1.5 minutes. So in patients with diabetes, the incretin effect is reduced or almost absent. So DPP-4 exerts its glucose lowering effect by the elevation of incretin hormones and subsequent augmentation of glucose-dependent insulin secretion, thus reducing hyperglycemia while minimizing hypoglycemia. So these agents, they do not induce weight gain, and they have proven cardiovascular safety in several large prospective CVOT studies. Now there's a rationale of combining the treatment options in diabetes. The rationale is because diabetes is a disorder where at a given time, multiple metabolic defects are seen. And it's a progressive nature of the disease of diabetes that also is there. There's limited efficacy of monotherapy, especially as the disease progresses. We need more and more drugs which have a different action. And there's a need to potentially preserve the beta cell function for as long as possible by reducing their persistent hammering by the increasing doses of insulin secretory clogs. So this can be done by adding combinations. And often there's a lack of a durable response with initial monotherapy and subsequent risk of microvascular complications with poor glycemic control. And if there is hyperglycemia, there is global toxicity. So hyperglycemia begets hyperglycemia. So this is a strong rationale for combining DPP-4 inhibitors and the SGLT2 inhibitor because the two drugs exert different complementary glucose lowering effects. This combination is speculated to prevent the compensatory increase in postprandial glucagon level. So DPP-4 inhibitors, being potent glucagon lowering agents, will counter the potential increase in endogenous glucose production. So DPP-4 inhibitors being potent glucagon lowering agents will counter the potential increase in endogenous glucagon production or glucagon or even both. Thus, combination therapy appears appealing and expected to be synergistic in reducing HbA1c. Moreover, pharmacokinetic and pharmacodynamic studies suggesting no drug-drug interaction between SGLT2 inhibitors and DPP-4 inhibitors, so making them a pharmacologically suitable combination. Metabolic studies with SGLT2 inhibitors demonstrated to improve peripheral insulin sensitivity and beta cell function. Theoretically, they could be used with any of the existing glucose-lowering agents in patients with diabetes, right from metformin to insulin. Now, another question arises: how will one guide his peers to choose the patient profile who would derive the optimum benefit from this combination, the combination of SGLT2 and DPP-4 inhibitors? So, empagliflozin, an SGLT2 inhibitor, and linagliptin, a DPP-4 inhibitor combination with complementary mechanisms and pleiotropic benefits may be suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or high-risk established heart failure, or even CKD, due to tolerability of the combination in addition to the potential benefits of empagliflozin on CV and renal outcomes, and no increased risk of heart failure with either agent. According to a study, early achievement of HbA1c goal of less than 7% with EMPA-LINA combination could reach target HbA1c just at 12 weeks compared to monotherapies, where it occurs very late or may not occur at all. So another point, what are the clinical experiences with EMPA-LINA fixed dose combinations and the rate of observed incidence of hypoglycemia while using this combination? Since the patient with type 2 diabetes may be at risk of non-adherence due to the complexity of treatment with multiple medications for the condition, in addition to the need for treatments for comorbid conditions and the requirement for self-care activities, the use of fixed dose combination therapy could simplify individual treatment regimens for type 2 diabetes and reduce the risk of non-adherence. Single pill formulations have also shown to improve around 12% higher adherence rate compared with loose dose treatment regimes in a systemic analysis of studies over a period of 10 years. Several studies conducted so far with the combination therapy of SGLT2 inhibitors and DPP-4 inhibitors find them an effective tool of HbA1c lowering, that too without provoking any further hypoglycemia. And associated weight loss reduction observed with this combination is an added advantage over DPP-4 inhibitor monotherapy. And interestingly, some studies have also found a reduced rate of genital urinary infections associated with the combination therapy rather than compared to SGLT2 inhibitors alone. EMPA-LINA combination is available as a first-in-class treatment in SGLT2 inhibitors and DPP-4 inhibitor combination group of drugs. DeFronzo et al. In their study to evaluate the efficacy and safety of combinations of EMPA-LINA as second-line therapy in subjects with type 2 diabetes inadequately controlled on metformin, found that at 24 weeks, EMPA-LINA combination showed statistically significant HbA1c reduction, minus 1.08 from the baseline, as an add-on to the metformin. HbA1c decrements by empagliflozin and LINA combination have demonstrated 1.81% HbA1c reduction and HbA1c baseline at 24 weeks. Change in fasting plasma glucose reduction with EMPA-LINA was around minus 32.2 at baseline, fasting plasma glucose of 156 at week 24, and maintained the same at week 52 in metformin-treated groups. Higher percentage of patients achieved HbA1c of less than 7 were reported for both single pill combinations versus EMPA 10 mg. In a study by Hutchins et al., an early achievement of goal was seen with only fixed dose combination therapies arm of EMPA-LINA, and it could reach target HbA1c at 12 weeks compared to monotherapies of loose pill combination therapy. Better adherence and compliance were observed with fixed dose combination therapies. In a study by Paulo Padini et al., where they screened the literature for randomized controlled trials, directly comparing the frequency of genitourinary tract infections in patients receiving DPP-4 inhibitors, SGLT2 combination therapy versus those receiving SGLT2 inhibitor only. A reduction in the incidence of genital infections associated with SGLT2 inhibitor was observed when a DPP inhibitor was added, perhaps because of a better glucose control, although possible mechanisms remain to be investigated. This unique combination lends itself readily to early treatment intensification because of good tolerability, low risk of hypoglycemia, possible weight loss, and minimal treatment burden. So, DPP-4 inhibitors and SGLT2 inhibitor fulfill a need for pharmacological agents with complementary mechanisms of action that can be used in combination to improve glucose control in a wide spectrum of patients with type 2 diabetes, with a low risk of adverse events such as hypoglycemia or weight gain, and the potential of cardiovascular protection. In summary, AMPA-LINA combination provides robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the goal, HbA1c, compared to the individual agents with low hypoglycemic risk. The combination offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight gain. Additionally, it would reduce the daily pill burden in this population, potentially improving adherence to and optimizing the benefits of treatment of diabetes mellitus. Thank you very much.